opportunity for us to exchange with you regarding the modern management of Moya Moya. I think we will be benefited from your presentation. Nice to meet you. Thank you.
Thank you very much. Thank you for inviting me. I'm very honored to be invited to such an eminent group, and you know, I think there are lots of important links that we can hopefully build on between our institutions, and you know, I think it's an important role that Great Ormond Street has in working with in other major children's hospitals around the world. So my name's Greg James. I'm a consultant neurosurgeon at Great Ormond Street. We have such a big department here. We're able to subspecialize within pediatric neurosurgery, and my particular interests are craniofacial conditions and what I'm talking about today, which are neurovascular conditions in children. I'm going to talk about Moya Moya, and although you very kindly introduced me as an expert, the actual lecture, I've called it Everything I Don't Know, because even for someone like me who deals with Moya Moya all the time and has an interest in it academically and clinically, there are still a lot of things we don't understand about the disease, and I'm going to try and talk about some of the advances and some of the new ideas we have. I'm very happy to be interrupted if you want any clarification or you want to ask any questions. I won't worry, and hopefully we'll have a little bit of time at the end for discussion if anyone's interested. Okay, I'm get the slides to work. So everyone knows this, Moya Moya. I mean, I think one of the important things about Moya Moya, which I always teach my residents and fellows, is that it's not really a disease. It's a radiological phenomenon, and a number of different diseases can cause a Moya Moya-like angiopathy. So in itself, it's not really a diagnosis. It's a description of an angiographic appearance. Everyone knows it's very common in East Asia. So it was actually, you know, named in Japan, means puff of smoke or puff of cigarette smoke. And a lot of people talk about this difference between Moya Moya disease, like Cushing's disease, a primary condition with no obvious cause, and Moya Moya syndrome, where it's related to an underlying cause like neurofibromatosis 1 or Down syndrome. And I'll talk a little bit about that and my views on that a bit later. The other important thing to say about Moya Moya, and I'll say this at the beginning, is it's very different in adult and children. It presents differently. In adults, it almost always presents with hemorrhage. It tends to affect people with the kind of atherosclerotic risk factors like smoking, diabetes, things like this. And it doesn't cause strokes in the same, whereas in children, it's almost an exclusively an ischemic disease. And really the management is quite different, and you shouldn't extrapolate what I'm going to tell you today into the adult world. The management of adult Moya Moya is completely different. It's not an area of which I have expertise because I work in a purely children's setting. So what I'm going to talk about today is purely about children. And pediatric Moya Moya is a disease that causes strokes, not a disease that causes bleeds. This is really important. So Moya Moya should not be managed by one person alone. It should not be managed by an individual. It's a condition that needs expertise of different backgrounds and different training. We're very lucky at Great Ormond Street to have a neurovascular team, which consists of 2 neurosurgeons, 2 pediatric neurologists. You can see there, Dr. Ganesan and Dr. Bhatte, 2 interventional radiologists, Dr. Robertson, Dr. Rennie. We have a dedicated nurse specialist, which is incredibly important in liaising with the family and for perioperative care. We have a weekly multidisciplinary board meeting to discuss all vascular cases, including Moya Moya. And we have a monthly dedicated Moya Moya clinic that I run with Dr. Ganesan. We operate between about 20 to 25 hemispheres per annum, which makes us one of the biggest centers internationally, particularly outside of East Asia. But one thing, again, I really want people to go away. This is not something where I'm saying I will manage these patients alone. Quite the opposite. This is a team enterprise and a team sport. So Moya Moya, what don't we know? Yeah, we don't really know what it is. I've told you it's a condition typified by its radiological signature, but we don't really understand its biology. I'm going to explain to you why I think it is important. What causes it, we don't really know. There are some genes that have been implicated in Moya Moya progression, but it's probably a combination of genetic and environmental factors in most patients. What's the natural history? One of the things as pediatric neurosurgeons is that we intervene on children that are growing and changing, and we don't always know whether the surgery that we do makes things better or whether things will get better on their own. And to treat a condition properly, you have to understand its natural history. And the natural history of untreated Moya Moya is relatively poorly understood. Which patients should be treated? Should all kids with a Moya Moya scan get an operation, or should there be some kind of patient selection? What are the medical treatments? What can we do before surgery to try and alter the natural history? And of course, for the neurosurgeons in the audience, what they'll be interested in, what operations to do and when. So very simply, Moya Moya is a disease of large arteries, mainly branches of the anterior circulation, although it can affect the posterior circulation. Less likely. The most commonly affected arteries are the internal carotids. It's an intracerebral condition. It does not cause extracranial vesicle narrowing, although some patients with a systemic vasculopathy can have both intracranial and extracranial involvement. But Moya Moya itself is, by definition, it is an intracranial pathology. And it affects really all layers of the artery. So it was initially thought to be an inflammatory condition, but there's never been any inflammation found. And in fact, if you look on post-mortem specimens, you will see abnormalities in all three layers of the artery, the intima, the media, and the externa. There is a strong genetic association in some families, particularly in East Asia, where familial causes are more common. And there is not a single gene that causes Moya Moya, so it's not a simple, what I call a neurosurgical gene, where you have one mutation causes one disease that neurosurgeons can understand, but a much more complex genetics. This gene, which is RNF213, ring finger 213, has been found to be an important risk factor, but it's a susceptibility gene, which means you can have the mutation and not have the disease. But if you do have the mutation, you're more likely to have the disease than if you don't. And it's probable that you have some kind of susceptibility, and then maybe something that happens in early childhood, an infection or other problem, which then results in the development of the Moya Moya phenotype. Obviously, as you all know, there are associations with particular conditions. Neurofibromatosis is one, Down syndrome, sickle cell, which is something that we see a lot in London because of our diverse community here, and some newly identified genes which people are still working through, really. This slide is just to show that abnormalities have been detected in really all layers of the artery. So you've got the intima, the media, and the externa. And if you look at post-mortem specimens, you will find abnormalities in all of these. I'm not going to go through all of these, but the point is it's not a simple disease of a one gene, one protein, one effect. It's a multifactorial condition where there's probably interplay between different genetic and environmental factors that cause the narrowing and the formation of the collaterals. One of the problems we have is that there is no particularly good animal model of Moya Moya available currently. This was quite a nice paper from the Neurosurgery Review last year, so it's free online, which looked at the different models available. And the traditional mechanical models where you basically clip or ligate the arteries in the neck you don't really get much collateralization, and probably the most accurate ones are these RNF213 knockdown mice, where you also induce a mechanical narrowing. So you have both a genetic environmental cause, and those that are probably the most accurate. But because we don't really understand the biology, we don't have a good animal model, which does hold back research into this condition. Why is it important? So ultimately, the reason Moya Moya is important is that pediatric stroke is important. Yeah. So stroke in children is common. It's as common as brain tumors, and brain tumors are the most common solid organ tumor of childhood. So children have strokes. You all know that, you're pediatric neurologists, neurosurgeons, but many doctors do not think of children having strokes. And so if an adult presents with a hemiparesis and a drooling mouth, and everyone knows it's a stroke, in children, diagnosis is often difficult to reach. Pediatricians don't think of it initially. But pediatric stroke is common, and most pediatric stroke is sporadic. And if you have a stroke, you don't have another one. But if you have Moya Moya, you will continue to have strokes. And that's why it's important to exclude in children who present with stroke. Moya Moya is the most important predictor of recurrent stroke in children. A lot of this research is from Vijaya Ganesan, my neurology partner, who's published extensively on the subject, and I would recommend you read some of her papers if you're interested in this condition. But lots of data suggest that if you present with a stroke, the chances of recurrence in childhood is pretty low, unless you have Moya Moya, in which case it's very high. It's the most malignant radiological signature. So if you have an acute ischemic stroke and you have an MRI scan that shows Moya Moya, that's the worst possible situation for you, because you're very likely to have more strokes. the other things I've kind of mentioned. So in children, it presents with this kind either obvious clinical stroke or often with this kind of gradual decline in cognitive function and behavior. That's quite different from adults, where it presents with bleeding. I've never seen bleeding. Untrue. I've had one case of bleeding, which was a MOPD dwarf who had Moya Moya and aneurysms. But other than that, I've not seen a child present with sort of classic idiopathic Moya Moya with a hemorrhage. But Jay Ganesan, who's a little bit older than me, has seen, I think, 2 cases in her career. So it is possible, but it's very rare compared to adults. Whereas in adults, it's the most common presentation, subarachnoid hemorrhage. What is the natural history? What if we do nothing? The best studies on natural history are from Japan, partly because they have a lot of Moya Moya. This is a nice study from the late 90s, so it's quite old, but this shows in untreated Moya Moya, over time, your IQ will decline. After 5 years, it drops from around normal or just below normal to subnormal. And at 10 years, you're into the kind of mental disability type range where you're needing extra help. So if you don't treat Moya Moya, you will accumulate ischemic injuries to the brain and your cognition will deteriorate, at least in all comers. And what we don't know, like I'm going to come to this, is if that's true for every single child, or we're looking at an average of a number of different kids. Intellectual function is affected. And the other really important thing is that if it's untreated, you have lots of stroke. This is a paper showing time of life, and that the black line is the initial stroke, yeah? And these boxes and triangles are further clinical events, either TIAs or strokes. And what you can see is once you have your first stroke from Moya Moya, you're going to have a lot more symptoms. You look at the clustering here. So these are untreated patients who, after their diagnosis of Moya Moya, their original stroke, go on to have lots and lots and lots of strokes afterwards. So when you present with stroke in Moya Moya, you need to act. You can't just ignore it. You have to treat it. This is just another thing showing the same thing. This is using the cascade categorization, which is an angiographic categorization. Essentially, this is everything that isn't Moya Moya. So if you present with a stroke, this is your chance of recurrence, and you can see it flattens out over time in most children. But in kids with Moya Moya, look, within 20 months, pretty much every child will have had at least one more stroke. I'm not going to talk too much about ACTA2 other than to mention it's an interesting protein mutations in which cause a very profound diffuse systemic arteriopathy. And part of it, that can be an intracerebral Moya Moya-like arteriopathy, which in my experience is very malignant and difficult to treat. And this is just some work from Vijaya Ganesan where she actually characterized the ACTA2 phenotype. And what's quite interesting is it has a particular angiographic signature with this narrowing, very straight, almost stretched out type arterial appearances. This is normal. This is sort of classic Moya Moya with narrowing and collateralization. And this is the ACTA2 phenotype where you have this very stretched vessels and relatively little collateralization, but quite severe narrowing of the arteries. And these are the kind of MRI scans you'll often see. So in adults, you'll usually see your classic kind of wedge-shaped acute ischemic infarcts. But in children, they often develop this kind of diffuse white matter disease, which can be confusing radiologically when it first presents. It often looks like other metabolic conditions. So which patients should be treated? Should everyone with Moya Moya get an operation? The problem is our treatment as surgeons is prophylactic. We don't make children better with our operations. Our operations are there to prevent them having further strokes. So we don't really know if our operations worked unless we know the natural history. And I've shown you some slides already to show you that if you don't treat Moya Moya, you will have lots of strokes. So we do know at least untreated Moya Moya in most children will be malignant. But those are children that presented with stroke. And increasingly we're faced with children who present maybe asymptomatic, and they've had the Moya Moya picked up because they've had an MRI scan for some other reason. We have to understand all of this. As a surgeon, when Moya Moya surgery carries risk. I've had children who've done badly after surgery, thankfully not many, but we have had. And you need to look the parents in the eye and tell them that you think the surgery is better than a natural history. And I'm not sure if all surgeons always understand that fully. But these are the challenges that face us. It is a rare condition. There is a lot of heterogeneity in the way it's managed around the world. So we don't really have a consistent guideline or plan. Each unit has its own ways of doing things. These are the American Heart Association Childhood Stroke Guidelines. This is from 2008, but they've recently been revised. I mean, essentially, to cut a long story short, they just say there is no evidence. So you have to make your choice on an individual patient basis. But generally, the feeling is that surgery of some sort is useful in Moya Moya in children. There's some evidence that you can improve the neurocognitive outcome, and I've seen that in patients we've treated. And when we look at the national level data, so this was a UK-based study looking at 94 patients, most of them from our centre, showed that majority of them had a good outcome, but there's still quite a lot of patients that even with surgery remain quite disabled. This is an interesting slide because this is a predictor of how likely you are to have a good or bad outcome. And the baseline is if you present with a stroke. If you present before you have a stroke, so if you present with TIAs or with headaches, you're much less likely to do badly, or you're much more likely to do well, which makes sense, but it's quite nice to see it. But what's quite interesting here are these two bottom parts. One is that if you have involvement of your posterior circulation on the angiogram, your odds ratio is 4 times worse to having a poor outcome, defined as a poor performance factor, a poor MRS grade. So that's a very malignant radiological signature and something that we look out for. The other thing is if you have a risk factor, so Down syndrome, sickle cell, and F1, you tend to do worse than if you're on idiopathic Moya Moya. And quite a lot worse, actually, 2.45. Interesting, in this study, surgery didn't alter outcome, as in whether you had the surgery or not didn't make things better, which doesn't mean the surgery didn't work, but it means that hopefully we're selecting the correct patients for surgery because they do as well as the patients that we manage conservatively. Asymptomatic Moya Moya disease, this is something that I increasingly see because certainly in the UK, it's much easier for access to MRI scans. So often now we have patients who may have presented either with no symptoms at all, but have had a screening scan, for example, a patient with neurofibromatosis, or presented with very vague symptoms like migraines or headaches, and the pediatricians arranged an MRI scan and found radiological Moya Moya, but with no stroke and a completely intact child. And again, in Japan, where they've got a big population of Moya Moya, they actually studied a whole island and looked at every single MRI scanned every single person on this island. And what they found is that actually of their 267 Moya Moya patients, about 20% were asymptomatic and they were just picked up on scan. So that's quite a large proportion. And I think it's difficult to know what to do with that group. It's very easy when you present it with a child who's had a stroke and has Moya Moya to advise on surgery. But for a patient that is completely well, has no symptoms, and has a stable MRI scan just with Moya Moya but no strokes, offering surgery is more difficult, and parents are less likely to accept it, and you feel less confident as a surgeon in understanding that. And we're actually working in a collaboration with Boston and Toronto to look at some kind of way of risk assessing the asymptomatic kids to see who might need surgery. Currently, if they're truly asymptomatic, I don't operate. I observe them with regular MRI scans and clinical review. Working a patient up for surgery is important. Proper clinical examination, which we don't always do as neurosurgeons. That's one of the reasons why it's important to work with a neurologist. Cafe au lait spots, ophthalmology, morning glory disc, these things are associated. Important to always do an echocardiogram. Cardiac and aortic anomalies are often associated. Getting an idea of blood pressure is really important, and actually as a neurosurgeon it's really important for your perioperative management, because you want to keep these patients at normotension or slight hypertension perioperatively to prevent stroke. And increasingly, I think in children, ambulatory blood pressure is better than individual measurements where children are often crying or distressed. We also now routinely do genetic screening for Moya Moya, and we have a panel where we look for things like RNF213, ACTA2, neurofibromatosis 1. and we pick up quite a number with that. The question is always often though what necessarily the relevance is. For mutations like RNF213, where we're not quite sure what the that means necessarily for the individual patient. Pre-surgical evaluation. So we do cross-section imaging, MRI scans. We do this phenomenon called the IV sign has been described first in Boston. So these are flare images which show hyperintensity in the sulci, and it's supposed to be a sign of slow cortical blood flow. And increasingly, it's something that we look for in the pre-op MRI as a sort of almost like a pre-stroke warning sign. I always do catheter angiography before surgery. I do not think it is safe to do surgery in the absence of catheter angiography. The reason why it's not diagnostic. You can diagnose Moya Moya on MRI or CTA, but what the angiogram will tell you is whether or not there are existing extracranial to intracranial collaterals from dura or even from scalp vessels. And you need to know that before you operate, because if you damage them during the operation, you will cause a stroke. So cross-section imaging cannot tell you that. You need to do an angiogram. We also, for new patients, do a renal angiogram at the same time as a cerebral angiogram. So there's about a 20% chance of renal vascular disease in these children. And that can be particularly relevant to their blood pressure management. Many centers use things like SPECT or acetazolamide, which are reactivity studies. Traditionally at Great Ormond Street, we haven't done those because in terms of surgical selection, I don't think they really help. If you've got a child who's had a stroke and they've got Moya Moya on their MRI, then they need an operation. And a reactivity study isn't necessarily going to change that. I have become a little bit more interested in them as potentially a follow-up for operated kids, particularly kids with very severe disease, where you may need to do more than one operation to revascularize different territories. But I'm not an expert on reactivity studies because it's not something that we've traditionally used in our preoperative workup. The other thing I think is really important for these children is to have regular neuropsychology assessments, if that's something you can access, because you need to get a feel of whether the IQ is stable or deteriorating, because that will also push you into surgical treatment. Medical options, unfortunately, there are not many. We routinely put all children with Moya Moya on aspirin. We use approximately 1 mg per kilo, but basically small kids get half a tablet, older kids get a full tablet. It seems to make sense, and it's used obviously in adult stroke, but there are no level 1 trials of aspirin in Moya Moya, and we don't have any good data to suggest it reduces stroke risk, but it seems a sensible thing to do. We continue it in all children operated or unoperated until 18, and then we stop it because of the worry about bleeding in adulthood, although again, no one really knows if children with Moya Moya go on to develop an adult phenotype of bleeding or not. Probably the most important thing, and that's the most important thing when you tell children, or you tell parents, is that you must keep these children well hydrated. If these children get dehydrated, they will have strokes. In fact, a child from Bangladesh who I operated presented because she had headache and was kept nearby mouth for an MRI scan, and therefore became dehydrated and had a stroke prior to the MRI scan. So for any procedure that will require a period of fasting, we admit children for IV rehydration. We advise parents that if they develop a diarrheal illness and risk of going dehydrated, they need to go to see a doctor and potentially have IV hydration. We recommend fluid targets for our children, oral fluid targets. Most Moya Moya kids like drinking because they feel better when they're well hydrated. So actually it's quite easy to encourage them. Blood pressure management is important. These children often present with hypertension because they need high blood pressure to perfuse their brain. We do not recommend dropping the blood pressure aggressively in these children. They will have strokes. So we work with our renovascular team and our blood pressure specialists, but usually we would do the surgery first before trying to drop the blood pressure down. The other really important thing is anemia. Many of these kids are often, I mean, you all know anemia is very common anyway in children. And if you don't have enough hemoglobin in your blood, your oxygen delivery is not going to be as good. So we give iron or even transfusions to keep the HB good, particularly perioperatively. Who needs surgery? Well, a randomized control trial is very difficult. It's a rare condition, and getting ethics will be difficult. What my practice or our practice here is that if you have had a stroke and you've got Moya Moya, you get an operation. If you have Moya Moya and you have multiple TIAs or evidence of radiological progression, you get an operation. If you've got Moya Moya and no symptoms at all, then we monitor you with regular scans. If you have Moya Moya, you maybe had one TIA. Those are a bit more tricky, but we often observe. What are surgical options? These are the things the surgeons are interested in. So this is my colleague, Dominic Thompson, and he invented this thing called TISI, the Thompson Index of Surgical Ignorance. And it's not just for Moya Moya, it applies across a huge amount of pediatric neurosurgery, which is, if you look in the literature, if you go to a meeting and you'll find someone who treats Moya Moya, they will tell you, I always do Pearson angiosis with muscle, I won't do anything else. You'll meet someone else in the next room who'll say, I always do a direct bypass, STA to MCA direct bypass. People who do indirect are wrong. And all these people will have very strong opinions, but it's not based on any evidence. There is no, it's a rare disease. Many operations have been described. There have been no direct, randomized or high quality trials to compare different techniques. There is some data which I'll show you, but currently, if anyone says to you what I do is right and what this other surgeon does is wrong, it's very difficult to prove that with any kind of science. Most of it's based on institutional experience and personal preference. So revascularization surgery. Revascularization surgery is very simple. That ICA is narrow. The normal supply of blood to the brain is interrupted. So you are going to bring healthy blood to the brain via an external carotid source. ECIC bypass, extracranial to intracranial bypass. There are many ways of doing that. They can be divided into direct and indirect techniques. So the classic direct technique is take out the STA and plug it straight onto an MCA branch. Something that that's how we started doing Moya Moya at Great Ormond Street. The problem is in children is the STA is often quite small and the blood pressure and flow is quite low. So technically you can stitch it under the microscope, anyone can do it, but you will find that the failure rate is quite high. And that's usually due to thrombosis forming in the bypass segment. The other problem with direct bypass is it tends to it revascularizes quickly, but it revascularizes a relatively small area. And I'll show you some angiograms later. Then you have your kind of complex high flow bypasses where you take, the things Lawton talks about. It's not really relevant in Moya Moya, they're more relevant to complex aneurysm surgery, but they have been described in Moya Moya as well. Indirect techniques are techniques where you don't directly connect vessels, but you bring on a vessel or vascularized tissue onto the surface of the brain, and we use an adaptation of the sort of classic Pearson angiosis technique with the STA. You can also graft on other tissues. Some people, take pericranium or muscle or mensum or dura, and there are combinations. So you'll have seen these sort of phrases, EDAS, EDAMS, which are basically a combination. So, for example, an EDAMS is an encephalo, duro, angio, myos, and angiosis. So it uses STA, it uses some dura, and it uses some muscle. That's kind of what we do, and I'll show you a video. So revascularization surgery. So direct surgery, the most obvious pro is that it supplies immediate revascularization, and that's why it's better in adults who bleed. So in adults, the evidence is quite clear that direct revascularization is probably better. It's also very cool, as you know, if you're a neurosurgeon and you go around telling people you do direct bypasses, everyone thinks you're really an amazing surgeon. The problems with it, though, are you get a relatively limited area of revascularization on the postoperative angiogram. The surgery can take quite a long time, and these children being under anesthetic is a risk factor for them. The longer the operation, the higher the risk of perioperative stroke. I've mentioned that with the very tiny vessels, it can be difficult to prevent thrombosis. And actually, most importantly, the evidence that we do have suggests it doesn't work as well. Indirect is very quick and very easy. You can do it right down to almost microscopic STAs. It will then hypertrophy over time. You get a very large revascularization area, but the downside is it does take some time for the new vessels to form. The question, parents always ask is how long? And the answer is, it's really driven by the child. If the child is very ischemic, vessels will form very quickly. I've done early post-op MRIs in kids because they've had a TIA or the concern at 3 or 4 weeks and seen revascularization at that stage. So if your brain is hypoxic and is pulling in new blood vessels, you will make You will make blood vessels quickly, but it's not as quick as a direct. There's been a few studies. This is from Journal of Neurosurgery a few years ago, shows that this is all retrospective data, but that indirect is better in terms of outcome, in terms of quality adjusted life years. This is from our own institution. This was published actually this year. We looked at a systematic review meta-analysis and showed that both indirect and direct are effective. That direct may give better early angiograms, but actually the clinical results are very similar between the two groups. So the evidence is they're probably about the same, or there's some evidence from the American groups that indirect may be better. The technique we use is the technique that really was developed by Mike Scott. I don't know if any of you know Mike. He's unfortunately very unwell at the moment, but he was really the pioneer of Moya Moya surgery in the Western Hemisphere. Dominic Thompson, one of my colleagues, then developed the technique further in Great Ormond Street, and we've developed it. Myself and my partner, Mr. Silver, have developed it further. We use an indirect revascularization technique, angiosis. We dissect out the superficial temporal artery. We keep it
Produce with.
So I think this is a really important slide. So the risk around this surgery is not surgical. The operation itself is very straightforward, and the risk of any bleeding or any of the sort of neurosurgical complications is very low. But these children will have strokes perioperatively if not managed properly. And we admit all children the day before for overnight prehydration. My practice with aspirin has stopped. Dominic used to stop the aspirin 10 days in advance of surgery. I now I just stop it actually on the day of surgery for a couple of days, which, as you know, probably doesn't make any difference. But the reason for that is we had a couple of patients who had strokes in that 10-day period while they were off the aspirin. So I now just continue it. It's a little bit oozy, the surgery, but if you're careful, hemostasis is not a big problem. You want to keep your operation quick, and you want to avoid post-operative nausea and vomiting. There's some quite good evidence from American groups that children who vomit post-operatively are more likely to have a stroke. And increasingly, I use intraoperative and post-operative monitoring. I use intraoperative EEG, which I think is excellent. And also we're looking into using NIRS for monitoring of the brain, because you just don't know if, particularly the contralateral hemisphere, the worst complication I've had was a major stroke in the contralateral hemisphere happened during surgery on another hemisphere. I'm going to show you a video. People like videos, so I'm going to show you this quickly. This is myself and Mr. Silver. We do these cases together. This is a 9-year-old girl with sickle cell disease. She'd had a right MCA stroke. So this is her MRI. You can see evidence of a previous stroke. Interestingly, often these children have very good function, despite these often bad-looking MRI scans, because they're young and they can recover function. You can see here the ICA injection. I mean, basically no flow into the brain at all. Here's the ECA, which is the donor vessel. You can see there's some collateralization already happening. Left side not as bad, but still some narrowing, and the ECA, there's no collateralization off of that. So she had bilateral surgery with EEG monitoring. We mark out the artery using a Doppler probe. We find it in the skin. The dissection of the artery is really ideally a two-person job. That's why I bring a colleague, because if you work as a forehand technique, you can be very slick and very quick. With children, the artery is often very superficial and very small. You have to be very careful at this stage not to damage it during opening the skin. I've only ever, in about over 100 cases, I've only ever injured the STA once, and we were lucky that there was a nice big posterior auricular artery that we could take instead. So it sits in this very superficial layer above the galea, where you're not used to working as a neurosurgeon. It's important to be very meticulous about hemostasis, because if you get a lot of blood on the artery, it will go into spasm. That was a microdoppler probe that we used. What you'll often see, and you can see it in this case, is there's often a big vein that runs next to the artery, and it can be quite difficult in small children to tell which is which, and a microdoppler is really useful. So the same microdoppler I use for aneurysm surgery, I use it for Moya surgery. So you can see you've got the STA, the chunky vein over the top, sacrifice. I leave a very generous cuff. Even if I'm doing a direct, you can cuff you just part. I open up you basically free the artery from the underlying tissue. It can be a bit oozy, patients on aspirin, but you just have to be careful and stop it. You want to then dissect to free your muscle flap. We use quite a nice temporalis muscle flap that I base anteriorly where the blood supply is best. And this will again be part of our revascularization tissue. Careful during this, obviously, not to damage the artery. I use vessel loops to just hold the artery in place so we can manipulate it once we're under the microscope. Craniotomy, standard craniotomy. We often check to make sure the artery is still intact, which it is. Generous burr hole, because I need to let your artery in and out. And then simple craniotomy, sort of easy. Like I said, it's not a difficult operation. Dura, we preserve the dural vessels. So you can see there are some nice chunky arteries here, particularly in this girl, because on the angiogram, some of them are actually supplying brain, but generally I think it's good practice to preserve the major dural branches. Remember, they're ECA branches that you can revascularize the brain as well. So we open the dura in this kind of stained glass window fashion where you leave the major arteries intact. Send a little bit of dura to the lab for look for any vasculitis. Never find anything really. So now you've got exposed cortex, and this is what's called a dural inversion flap. So we push the dura under the edge because again, it's part of your revascularization. Now we're under the microscope, and this is a really important step. This is what Mike Scott described, which is the opening of the pia arachnoid over the recipient arteries. So get rid of all those. Remember, this operation, you're helping God, you're helping nature. This brain is hungry for blood. It wants to make new blood. So you're giving it the opportunity to do that by bringing the healthy artery onto these arteries and leave as little biological material between them as you can. So you have naked arteries, and then you have your vessel right on top of them. And it means new vessels will form very quickly. So this can be quite a fun bit under the microscope, just opening these up. You have to be careful not to get any bleeding because obviously you don't want to buzz anything. And then this is the pielsenangiosis. We use 8-0 or 10-0 proline to stitch the graft directly to the pia. And again, this is what Mike Scott describes. I usually use just 2. Some people put 3. Just really to tack it down, to keep it hard up against the brain surface, allowing new blood vessels to form. Slightly strange as a neurosurgeon to stitch the brain, but the pia actually has quite good strength to it. You can usually get a good stitch. We put the muscle back over the top and stitch it to the dura, which both seals off the CSF and also is very good for blood supply. You have to trim the bone. You have to trim quite a bit of bone because what you don't want to do is compress the artery or compress the muscle, and then you close. So this is just an example of how things look. So this is a pre-op patient. Bad Moya Moya, you can see here. This is the STA prior to surgery. So you can see all going outside. And then this is 1 year post-surgery. You can see now, this is an injection only into the STA or into the ECA. You can see how much brain is being filled. And that's the beauty of the indirect technique, is you'll get these very impressive post-operative angiograms with very good filling of the hemisphere. This is another analysis from a group that looked at indirect and direct procedures. I'm not going to go through this again, but essentially shows very similar outcomes, although probably a slightly higher. Interesting, in this study, there was a slightly higher early stroke risk in the indirect technique, not something that we've seen in our own practice, I think, and I think a lot of that comes down to anesthesia. This is from our own work, quite an old paper now, but each one of these is a child. The black line is prior to surgery, and each of these tick crosses is a stroke. You can see some children have had multiple strokes prior to presentation, and this is after surgery, and you can see the chances of having strokes is very low. Just 3 patients had a clinically significant stroke post-operatively. So patients were having lots of strokes, and they have the surgery, the strokes stop, basically. This is data that compares from several big Western centers, Great Ormond Street, Stanford, Gary Steinberg, who's one of the big Moya Moya guys in the States, Mike Scott, John Hopkins. So you can see there are differences. We used to do quite a lot of directs, but we've really switched now to the indirects. Mike Scott did all indirects. Gary Steinberg does quite a lot of directs, although he doesn't really talk about it. He does quite a few indirects as well. The important thing with all these relatively big studies is the risk. All of them have reasonably good outcomes with relatively low long-term post-operative stroke rates, but there is a mortality. There were no mortalities. We've had actually 2 mortalities in the whole series since the original paper. And usually it's not due to surgical complications, but perioperative stroke due to anesthetic issues. And that's one of the reasons why perioperative management is so important. And this is just to show a more recent series. This was published a couple of years ago, which just showed that new surgeons came in, took over from Dominic, who stopped doing the neurovascular procedures, but our actual stroke rates and outcomes are very similar. So I'm going to finish up now. Moya Moya, it remains a poorly understood condition, particularly its biology. I think, like I said, I don't think it's one disease, but it's a radiological outcome that various diseases can feed into, and it probably has a genetic and environmental factor in many patients. Children presenting with stroke, TIA, and radiological Moya Moya should be assessed by a specialist multidisciplinary team. I can't really emphasize this enough. You need to have a neurologist and a neurosurgeon, radiologist, nurse, anesthesiologist have an interest in this condition and some understanding of it. I think there is a good paper from the Boston group which showed that people who are doing these surgeries in isolation, the results are not as good as when you do it in a center. And revascularization surgery is safe and effective for preventing stroke in Moya Moya, although we're still learning how to optimize our perioperative management, and the surgical technique remains in evolution. That's my talk, and thank you very much for allowing me to talk to you. Like I've said, it was a great honor to be invited, and I know it's taken a bit of time to organize, but I'm very pleased that we managed to meet and talk today. And if you have any questions for me, I do have some time, 10 minutes or so. If anyone wants to ask any questions or make any comments, I'll be very happy to do so.
James.
Thank you, Professor James, for your nice deductive and elaborative lecture. We also introduce our teacher, our Joint Director of National Institute of Neurosciences and Hospital, our Honorable Professor Badrul Alam sir, and he liked our subject, pediatric neurosurgery, very much. They also developed this hospital and our subject also. And I also introduced today's another panelist, Dr. Jahid Hussain sir. He is head of the Department of Neurosurgery of this hospital. So now we can discuss, and some question we see in the chat box. Sir, please start.
Thank you, Professor James, for your nice and very brilliant lecture on Moya Moya disease. I have a few idea of the Moya Moya disease, but I have a question regarding treatment of this Moya Moya disease. It's a genetically influenced progressive disease which causes intimal thickening, that is fibroelective thickening of the intima of brain fat. So when we do direct bypass over the MCA branches with STMCA, there is STMCA bypass, what will be the fate of this bypass in a later on when this progressive disease may involve the MCA in a later stage of the disease, then whether bypass will block or will function in the future?
Yeah, I think that's a very good question, actually. And I mean, the interesting thing about Moya Moya is it seems to affect large vessels much more than small vessels. And in fact, small vessel involvement suggests an alternative diagnosis usually. So by the STA-MCA bypass, you're really revascularizing the cortical arterial bed, which seems to be not affected by the hyperplasia and thickening that you see in the, the ICA and the proximal MCA. As I said at the beginning of the talk, the problem is our understanding of the biology is limited, and we don't have a good animal model. We're trying in my lab to develop one, but we don't have a very good reliable model for Moya Moya. I guess what I can say is that once we see on an angiogram, so our follow-up program at Great Ormond Street is to do an MRI 6 months after surgery, and then a catheter angiogram 1 year after surgery. If we see a patent STA to MCA bypass at 1 year, I have never seen that then occlude later on. So once the bypass is established, it remains open, and Moya Moya doesn't affect the external carotid branches.
Thank you. I have another question. In indirect bypass, we sometimes do EMS. That means myosynergiosis.
Yeah.
In that case, whether there is chance of seizure or convulsion in the later on of the babies.
Yeah, so that's interesting, because it's a point of disagreement between us and the Boston group. So I work very closely with Dr. Scott and his successor, Dr. Smith. But most stuff we agree on, but one thing we disagree on is the muscle. So we use muscle, as you saw in the video, and we've not had any patients who've developed post-operative seizures. We've had some patients who've had epilepsy prior to surgery and continue to have epilepsy, but we haven't had new seizures in any of our cases. But the reason the Boston groups is for exactly what you've said, say that they don't use muscle because of concern about epilepsy. I mean, I guess I kind of understand in a sort of theoretical way why people worry about it, because you've got a contractile tissues that on the brain surface, but it's just something that we don't see in our practice. And if you look at the data, like I said, although it's almost entirely retrospective, the data in those meta-analyses I showed you that doesn't show an association between the use of muscle and epilepsy.
Thanks. I'm Professor Badrul, Professor of Neurology and Joint Director of this institute. Last few minutes I have learned a lot, particularly the Moya Moya. You know, this is the tertiary level hospital. This is the neurosciences. This is 500-bedded hospital, but a few of the beds are dedicated for the pediatric neurosurgery. Only 30 or 32 bed yet. But we have a vast majority of population in our country. And I think there are a large number of people or babies or children are suffering from Moya Moya disease. So in near future, how can you help that? What number of patients are actually in Bangladesh? In what respect you can help us to do this research job, that we should calculate the number of burden in our country, number one. Number two, is it needed to do the screening test for the baby, for particularly the angiogram, those who are suffering from headache or any type of illness? And another thing is that sometimes we give aspirin to a patient of Moya Moya disease, but some of the patients behave with hemorrhage. So is there any predictor or any denominator that we can assess previously that patient may have perhaps with ischemic stroke, or that patient may behave like hemorrhagic stroke, so that we can choose aspirin or not?
Yeah, I think those are all good questions. I mean, certainly, I think Moya Moya is a rare disease. I think it's important, you know, it's because we're like you, a tertiary centre, we attract a lot of referrals. So I see it all the time. So in my mind, it's not a rare disease, but you must remember that it is within the population a rare disease. But I think it goes back not just to Moya Moya, but to pediatric stroke, which is that, you know, as I said right at the beginning of the talk, pediatric stroke is an important and common condition, but it's underdiagnosed because most doctors don't think of children having strokes. It's not an obvious thing. For you guys who are experts, you will consider it in your diagnosis, but for many general practitioners or general pediatricians, they won't necessarily And the presentation of stroke in children is often quite difficult. It's not the classic hemiparesis or whatever you'll see in an adult. Can often present with change in behavior or epilepsy sometimes, or tic-like movements, so I think even before you get to worrying about Moya Moya, you have to kind of think about whether the stroke workup is, and even in the UK, which is a relatively wealthy country, there's still often delays in diagnosis of pediatric stroke because it's not always thought of. In terms of the case burden in your country, I mean, I guess you have, that would be an interesting piece of research to do. We'd have to have a look. I mean, we see obviously the UK in London particularly is very multicultural and diverse, and we do see a lot of South Asian people with Moya Moya. It affects all races. It's traditionally thought of as a sort of Japanese disease because of the name, and it is more common in East Asia, but we see it in African people of African descent. We see it in people of South Asian descent. We see people of European descent, so it can happen in anyone. The last part I think was about the aspirin. So as I said at the beginning, I think pediatric and adult Moya Moya are essentially different diseases. They have the same name, which leads to people kind of often grouping them together, but the way they present, the way they evolve, and even radiologically, they look quite different. But I think most importantly, Moya Moya in adults is a hemorrhagic disease. Moya Moya in children is an ischemic disease. And therefore, on the balance of probability, the use of aspirin is probably indicated in children with Moya Moya, and the risk of bleeding from the aspirin is very low. Our protocol is to treat children up to the age of 18 with aspirin and then discontinue it at age 18. Obviously, it has to be a slightly binary thing. 18, it could be 16, 21, you can choose. But that's the decision we've made based on the data that we have. All I can say is in our as I said during the talk, in our very big caseload of Moya Moya, we've only seen 3 hemorrhages. And those are usually related to aneurysms.
Thank you, James, for your eye-opening presentation regarding the Moya Moya disease, especially the identification and evaluation of anemia, then your blood pressure, then angiogram, cardiovascular status, even the pre-surgical hydration technique. So actually these few points were eye-opening for me, but I have a few questions to you regarding the pre-surgical evaluation. What is your preference? Is this CT angiogram or the MR angiogram?
We use MR mainly. We use MR and catheter angiogram. So MR predominantly to look to the brain to see for evidence of ischemic lesions. So to look for strokes, to look for that kind of periventricular white matter change. So it's interesting that the ischemic phenotype radiologically is very age dependent. So in babies, they often don't have classic sort of major territory infarcts, but they will often have more diffuse white matter change around the ventricle, whereas older kids have more of the classic, wedge infarcts that you see in adults. So the MRI scan is really important to judge the stroke burden, basically. The angiogram, the formal angiogram, I think is important for a couple of reasons, the catheter angiogram. One is diagnostic, because you can tell Moya Moya on an MRA, but the diagnosis is really made on an angiogram, and it will give you more accurate information about which vessels are affected and how severely. But I think, like I said, from a pre-surgical point of view, the most important reason to do a catheter angiogram is to demonstrate the presence or absence of spontaneous EC-IC collaterals. So if a patient already has, for example, blood vessels from the dura that have grown into the brain, which can happen with, without surgery, they're basically doing their own bypass. You need to be aware of that prior to operation, because if you damage that vessel, then you can cause a stroke, and you won't see that on any other modality other than catheter angiography. So that I know there are some centers around the world that will operate just on the MRA, but I think it's unsafe.
Okay, thank you. My second question is to you. What is your post-operative schedule regarding the follow-up? How frequently do you offer MR angiogram during the post-operative follow-up period, and for how long?
Yeah, so we actually follow all these children long term. So we would do an MRA and an MRI 6 months post-surgery. And then we would do a catheter angiogram 1 year post-surgery. And then if that's satisfactory, we just do annual MRI and MRA, predominantly to make sure there's no more ischemic lesions developing. And we would do that actually until adulthood, and we have a transition arrangement with the adult neurologist where the patients go to the adult neurology where they continue to follow them, although they often scan them less frequently in adults. They reduce the frequency. It's difficult because no one really has a lot of very good long-term data, so it's difficult to say, okay, at 5 years the risk goes away. And certainly, I mean, I guess it's quite resource heavy, and we're lucky in the UK to have access to scans relatively easily. So for us, an annual scan is not a big problem. But I think, you know, so you do occasionally see, for example, children we've done STA to MCA bypasses, but also have posterior circulation disease. You'll sometimes see the hemispheres are protected, but they may start to develop occipital or cerebellar problems. So I've had a couple of patients where I've had to do revascularization surgery at the back of the head as well. And you won't pick that up necessarily unless you do the MRI follow-up.
Okay, my third question is to you regarding the epilepsy issues in Moya Moya disease. As it is evident, the child is suffering from recurrent ischemic stroke, and there is a high chance of tissue damage. And so there is a chance of occurrence of high frequency of focal epilepsies in these cases. What is your preference regarding the choosing of the anti-epileptic drugs, and for how long one should treat? And what is your practice at your center?
Yeah, that's a good question. So, I mean, obviously I'm the neurosurgeon and I rely on my neurologist for a lot of that. But generally, and there's data both from our group and other groups, that the epilepsy often improves after surgery. So what I would tend to do is, you know, I wouldn't necessarily make a choice of agents, and that's done by the neurologist, but typically would be something like maybe Keppra. I would continue it for at least 6 months post-op. And then if the child is well and not having any symptoms, I would discuss with my neurologist about whether we would do an EEG maybe, or just wean it. Because actually, I think one of the problems is there's in my mind, increasingly, there's a sort of overlap between what we call TIAs and what we call seizures. That, you know, you have these kind of focal neurological events happening in the brain due to abnormal blood flow, and they can present in children in a seizure-like way, but they may be driven by ischemia. So once the surgery, you've done your surgery and the blood flow's improved, often those symptoms do actually improve on their own. There are a group of patients, particularly patients with syndromic conditions, who will continue to have TIAs even after successful surgery, despite not having strokes. And often they can be quite difficult to manage, but often we tend to use things like try and push the blood pressure up. So sometimes we use things like fludrocortisone, fluid hydration. We sometimes even use oxygen when they're getting the TIAs to try and improve things. So rather than going always to anticonvulsants, because they can often have quite a lot of side effects in kids. But I think it has to be a patient by patient decision, I think.
Okay, thank you again for your brilliant comments regarding these practical issues. Thank you again.
Hi, Tazib. How are you? How are you doing? Oh, I remember you. Yes, I remember you. Yeah. Nice to see you.
Thank you, Professor Greg James, for your excellent talk. I have a few questions. What is your experience regarding practical outcome in different stages of Moya Moya disease?
So can you just repeat that? Different outcomes in different
stages of Moya Moya disease. That means the Suzuki classification of Moya Moya disease, angiographic stages. What is
Oh,
what is your experience regarding practical outcome in different stages of Moya Moya disease?
different stages, yeah. So to be honest, we've, as you probably know, you may, for the neurosurgeons, you will have noticed I didn't really talk about grading systems in my talk. So there are angiographic grading systems, so like the Suzuki grade, which are grades of severity of Moya Moya. Our experience has been that the angiographic grade is less important than the clinical presentation generally. So children who are presenting with recurrent stroke are already in a much, regardless of the angiographic severity, are in a worse prognostic group. And actually, sometimes the patients with the worst angiograms, as in they have the very narrow vessels with a lot of collaterals, actually are making collaterals well. So they're actually managing to maintain their brain perfusion better than patients with so-called early stage, where you've just got narrowing and no collateral. So generally, we don't really use, we look at the angiograms but we don't tend to use the staging to alter our surgical decision. The surgical decision is predominantly made on clinical grounds in terms of presentation, symptoms, and in combination with the radiology, rather than saying, okay, grade 2 we don't operate, grade 3 we do operate. So I'm a bit of a skeptic to how useful it is actually, particularly in children.
I have another questions. What are the criteria you consider to do direct revascularization in Moya Moya in pediatrics?
Yeah, so to be honest, when we started the program, or when Dominic Thompson started the program, he did all direct bypasses initially, and we've really moved now to the opposite end of the spectrum, where we pretty much do indirect bypasses. The only times really I will do direct bypasses now is for aneurysm surgery, if you have to bypass an aneurysm in a non-Moya Moya patient. I think the evidence in my mind is so strong that the indirect technique is superior in children, and it's just so much quicker. My worry with these kids, like I said, isn't the operation, but the perioperative period. And, for a single side Moya Moya, it takes us a couple of hours and the kids are home within 3 or 4 days. Whereas if you're doing a direct, is a much longer operation, much longer anesthetic. And my worry is the stress that puts on them physiologically. So my partner, Dr. Silva, he spent some time in Phoenix with Lawton, so he's very keen to do direct bypasses, and he's often, but we haven't really found any patients where we think at the minute it would offer an obvious advantage over indirect. I guess the one group that we may consider it would be an older child, maybe an older teenager who's presented with a hemorrhagic, so more like an adult presentation, because I think the data in adults is that in that type of situation, a direct bypass probably is important to reduce your bleeding risk quickly. But like I said, those presentations are so rare that it's not a situation that I come across very often.
Thank you. I think Dr. Jia has some question.
Yes, sir. Thank you, sir, for giving me the opportunity. I have a question to Professor James. Hello, sir.
Yeah,
can you hear
go
me?
Ahead. Yeah, I can hear you. Yeah.
Yeah, sir. Is there any age demarcation above that we should try direct bypass? In our institution, we deal with patient of up to 18 years of age. We deal with patients of up to 18 years of age, 18 years or below, and we are doing all indirect bypass. Are we doing the right thing? First question, are we doing the right thing?
I think so, yes, I think you are. I mean, like I said, on the data that from our meta-analysis and from other publications over the last sort of 5 years or so, I think in children, I mean, like I said, it's really important to differentiate children and adults. And in adults, there is quite good evidence that direct bypass reduces your risk of bleeding quicker, which I think is important. But in children, which is an ischemic presentation, we present with TIAs and strokes, indirect bypass is better at protecting them from those problems. So I think what you're doing is right. You know, and I think the interesting question for me is, for children who have Moya Moya as children, what happens when they become adults? Do they become an adult Moya Moya phenotype, or do they keep a pediatric phenotype? And I think the evidence that certainly our experience is that from the adult clinic we send patients to, is that the children stay like, so even though they're adults and they're grown up, they remain very stable and they don't seem to run into the bleeding problems that patients who present in adulthood with Moya Moya have. So the synangiosis they have done as children seems to protect them long term, even into adulthood. And in fact, there is a long-term follow-up paper from Mike Scott's group, which also shows that. Although, you know, it depends very much on the underlying cause. You know, if the children are otherwise healthy and it's an isolated Moya Moya, they do very well. If they've got other issues, you know, NF downs, other things, obviously that can affect the long-term outcome more.
Thanks, Gia, for your question. Can you have any question? Any more question? I think Dr. James, there are some question in chat box. Please comment on that question.
Oh, question in the chat box, yeah. So I think this is from Tazib's family, one of our patients, who's asking about aspirin. So we continue aspirin until age 18. I think that's a good idea. Anticonvulsions, like I said, I think it has to be a decision between the neurologist. But if the patient is, you know, if you're talking about Tazib here, but any patient has not had any seizures for a long time, then I think, you know, trying to wean off the medication is reasonable to try. There's always a risk, obviously, of seizures coming back. But generally, our experience is once the surgery is done and you're past that kind of 6 months post-surgery, actually, the risk of epilepsy really decreases a lot. And there's a question about post-op angio. So yeah, so we always do a catheter angiogram 1 year post surgery. I think that's important to document the bypasses. It's not, is it? I guess, you know, we have discussed as a group whether, because obviously it's quite an invasive procedure, but whether or not it's completely necessary. Because if the patient is clinically stable and the MRI scan looks good, you can add question, what does the angiogram add? I think it adds a couple of things. I think it lets you understand if there's any progression of the native disease, so whether the actual Moya Moya's got worse, because even after successful bypass, the actual ICA and MCA narrowing can continue. And I think it gives you the best idea of your bypass outcomes in terms of, you know, how much of the brain is supplied by the bypass. And I think that is useful, not just as a surgeon because you're interested in your own operation, but I think as a prognostic sign to the family to say, look, there's a large area of the hemisphere revascularized, which is a good sign, and therefore you can probably be more relaxed than if we saw a less impressive revascularization. So, but I only do one catheter angiogram post-op, and then the rest is all MRI.
Thanks, Dr. James.
I have one question.
You use for fear and pain.
Yeah, so I mean, that's probably more of a question for an anesthesiologist, but I think it's important that you, so I think when you do this surgery, it's important to have an anesthesiologist who understands the importance of the perioperative management. So Dominic always used to use one anaesthetist. We've tried to now increase that to a number of anaesthetists who have got experience, but I think the perioperative management is really very critical in terms of, yeah, like you say, keeping the child calm and you know, I think nursing has an important role as well. We have a dedicated neurovascular nurse who spends a lot of time with the family, so they know what to expect. The child knows what to expect. I think getting good venous access in advance is important. So quite often now we will put a PICC line or similar kind of line in, so the child hasn't got to be exposed to lots of needles. You know, interestingly, in Boston, they will often run a dexmedetomidine infusion for some children, particularly like the Down syndrome kids who are very, you know, don't understand what's going on, to keep them quite drowsy. I worry about that slightly because obviously you also want to be able to assess them neurologically. So I think you have to work again with your own department and your own anaesthetist. But what I recommend is you find an anaesthetist who has an interest in the condition. who will be sympathetic and understand the importance of the pre and post-operative management. And they have that in Boston. They have an excellent anaesthetist called Dr. McLean, who's really taken an interest in this perioperative management and has published lots of papers on it. So I think getting someone interested and engaged is the most important thing. And then you can develop your own kind of perioperative management with that person.
My another question, though the answer is may not straightforward, can we develop a guideline that which patient need actually direct anastomosis and which patient need indirect anastomosis by considering the angiographic stage, clinical status, and as well as other features and age also? Is it possible to develop a guideline that which maybe
so
a small group of patients need direct bypass, but which group actually need direct bypass?
So there are a couple of guidelines. There's one from the European Stroke Association, and there's one from the International Pediatric Stroke Association. The problem is that because the data, like I said, is quite poor quality, they're always based on sort of Delphi consensus opinion rather than level 1 data. So that these guidelines are always ultimately going to be a suggestion rather than a very strong recommendation. Like I said, my view is that in children, indirect is your first option. It should be your first option. It's safe, it's quick. The evidence suggests it's equal to or possibly better than direct in children for presenting ischemic stroke. So in my mind, the guideline's quite simple. You do it in my hands. Indirect surgery works well. But there are guidelines. I mean, I can dig them out and send them to you, but they're not. The problem is, like I said, because it's a rare disease and the data is quite scant, you're never going to have a very definitive guideline like you could with, say, adult stroke, where there's huge studies of thousands of patients. I'm afraid I'm going to need to go quite soon. Under 2 experts, so I can't tell them what to do. In the UK, we would usually continue the aspirin until age 18. Because it's usually well tolerated. It has very few side effects, and it probably does help improve brain blood flow. We don't have very clear scientific rather the aspirin. Yeah, so like I said, when I took over the Moya Moya surgery from Dominic Thompson, he used to stop the aspirin 10 days in advance, which is like a traditional neurosurgical thing. The problem was we had 2 patients. One of them had a stroke coming into the hospital because during that period, and so I gradually reduced it to 5 days, and now I don't stop it. I continue the aspirin until the day of surgery, and then I just omit it for 48 hours, so they don't have aspirin on the day of surgery or the second day. If you know the biology of aspirin, you will know that doesn't make a lot of sense pharmacologically, because it takes at least probably 2 weeks for the aspirin to wash out of the system. So Boston, they don't stop it at all. They even give it on the same day as surgery. So I personally think, remember, this is not that's another advantage of the indirect technique. You're not going inside the brain. This is on the surface. So the risk of intracranial intracerebral hemorrhage is very low. So as long as your surgical technique is sound and your hemostasis is sound, I don't think it's an issue for them to be on aspirin. So I don't have strong feelings of it, but I think stopping it very aggressively probably is not a good idea. Okay, I have another meeting, I'm afraid, in like 3 minutes, so I'm really going to have to go, I'm afraid. But thank you so much for inviting me. I really enjoyed it, and the questions were very interesting.
Thank you so much. Also, that I hope we will get your support in future, because this is a need for our development. And thank you very much for other audience for joining actively, and our honorable teacher as well as other people. Thank you very much.